So I see we have 50 some participants who've come in already. Welcome, everyone. And just a reminder that the panelists can use the chat to communicate with each other.
Okay, I think we're going to get started. Welcome everyone to our webinar on addressing concerns about the COVID-19 vaccine. We are very pleased that you are joining us today. This webinar is for you. We welcome you to ask all questions after our panelists present. I am Professor Michele Greene from the Department of Health and Nutrition Sciences at Brooklyn College. The webinar is being sponsored by our department, the Center for Health Promotion at Brooklyn College, the Brooklyn College Health Clinic, and the Public Health and Medicine Student Club. The Department of Health and Nutrition Sciences, composed of faculty from many disciplines, has been addressing the issues around COVID-19 in many of our classes. As part of this effort, we developed a course specifically on COVID-19. It's called Health and Nutrition Sciences 5191. We'll be offering the course in the fall, and there are no prerequisites, so it's open to the entire Brooklyn College student body. If you have questions about the course, I'm going to put my email in the chat, and you can contact me. So to get started, we have some housekeeping. Please note the webinar is being recorded and it is also live streamed. The chat is disabled. Please put your questions for the speakers in the Q&A box. We'll try to get to as many of those as possible. And before we begin, we're going to, we have a poll for you that you should be seeing on the screen momentarily, and we'd appreciate your responses. The poll, by the way, is completely anonymous. We will not know who responds in what way. And after the poll, I'm going to hand this over to Professor Raymond Weston, who is going to be our moderator. Can we launch the poll? Who is going to be our moderator?
I apologize, everyone. There seems to be a delay and feedback on the sound.
Can we launch the poll?
Yes, we can certainly launch the poll. I just wanted that to be addressed. I'm going to launch
Who is going to be our moderator?
I apologize, everyone. Thank you for everyone who's responding to the poll. We have, it looks like we have 148 participants, and a large fraction have responded to the poll. All right, Michele, would you like me to end the poll?
Yeah, thank you.
All right, thank you to everyone who responded. We have 103 responses. Make sure you also scroll down to question 2 about your role at this meeting, whether you're a student, staff, or faculty at Brooklyn College or another college, or a community member or a health professional. All right, I think we're gonna get started on our next. So thank you very much. I'm going to end the polling.
And Professor Weston.
Thank you, Professor Greene. Good afternoon. Again, thank you, Professor Greene. Good afternoon to our speakers, the Brooklyn College and CUNY-wide community, and all guests who have joined us for this discussion. Our guest speakers today are Dr. L. Janine Bookhardt-Murray and Dr. Donald E. Moore. Both are practicing clinicians in 2 of the areas most severely affected by the COVID-19 virus in New York City. Dr. Moore in Brooklyn, Dr. Bookhardt-Murray in the Bronx. But before I introduce them to you, let me provide context to our discussion. A little more than a year ago, the world was faced with the deadliest public health threat in over 100 years. A novel coronavirus that rapidly spread from person to state to country, leaving sickness and death in its wake. Countries shut down all but essential services. Populations were told to stay at home when possible, to wear masks and maintain a 6-foot distance from others when it was necessary to venture outdoors, and to pray for a scientific breakthrough to halt the spread of the COVID-19 virus. While we prayed, over 3 million individuals succumbed to COVID-19 related causes. The world was consumed with questions regarding the virus. Where did it come from? What are some communities bearing an undue burden of morbidity and mortality? And how long will it take to develop a vaccine? And then it appeared that our prayers were answered. A vaccine was developed in record time due to an unprecedented collaboration of health scientists around the world. However, this seeming miraculous accomplishment raised more questions than it answered. How could a vaccine be developed in such a short time? Is this a traditional vaccine or something else being called a vaccine? What are the long-term risks of this vaccine? And can those communities hardest hit by the virus trust the scientific community to act in our best interests? Thus, we are faced with a simple but profound choice: to take the vaccine or attempt to wait out this modern plague rather than risk additional harm from a novel vaccine. Aware of the extreme ambivalence that has led to the coining of a new term in public health, vaccine hesitancy, the HNSC department sought to address these issues in the classroom. However, it soon became evident that the scope of this crisis required more than it required a forum in which the Brooklyn College community could receive information from the gatekeepers of the hardest hit communities regarding the myths versus the realities, the pros versus the cons, and the effectiveness versus the hype of the COVID-19 vaccine. At the conclusion of this information session, we expect you to have a better sense of these essential issues. Concerns expressed by high-risk individuals regarding both the virus and the vaccine. Outcomes to those who have taken the vaccine, as well as to those who have not taken the vaccine. And recommendations for individuals and communities in the coming months and years regarding the COVID-19 virus and other public health threats. Now, it is my distinct pleasure to introduce Dr. J. Janine Bookhardt-Murray. Dr. Bookhardt-Murray received her medical degree from the University of Colorado Health Sciences Center. Upon completion of medical school, she accepted an internship and residency at Columbia University at the Harlem Hospital Center. Her subsequent positions include clinical instructor and attending physician at the Columbia University Department of Medicine and Psychiatry, adjunct professor with City University Sophie Davis Biomedical Program in the Department of Pharmacology, associate medical director, clinical director of HIV services, and director of adult medicine at Morris Heights Hills Center, consultant to the Office of the Medical Director at the AIDS Institute of the New York State Department of Health. Her private practice focuses on the care of adults with chronic illnesses, such as HIV and diabetes. Her scholarly activities include lead authorship on the chapter of HIV antiretrovirus side effects. She is a peer reviewer for numerous publications on the topic of HIV and AIDS. And Dr. Bookhardt-Murray has set standards for the identification of mental health disorders in patients seeking care in the primary care sector. Dr. Bookhardt-Murray, welcome. The floor is yours.
Thank you very much, and good afternoon, everyone. Thank you, Dr. Weston, Professor Weston, I appreciate that. And hello to all the participants, and I'm glad to be here. I'm going to share my screen and see if, where did it go? I don't think I can share my screen because my slide disappeared, but I will just talk because my slides were really just an overview of what I'm going to speak about. So I know all of us have been through more than a year now of COVID, and I hear people make comments a lot about how tired they are of wearing the mask and distancing and not being able to travel and so on and so forth. So hopefully we can get through this today and you will feel much more hopeful about the world going forward. SARS-CoV-2, oh, there it is. Thank you. Thank you very much. All right. SARS-CoV-2 is the virus that causes COVID-19 infection. And as you know, the symptoms of infection can range from very mild to things like a cough or a sore throat, gets better in a few days, all the way to severe shortness of breath, resulting in, and can result in death. So we see the whole spectrum of illness. In the Bronx, we've been hit pretty hard. And at this point, things are lightening up a bit. But the death part is, of course, what the vaccine is all about. So I've been asked to speak about vaccines, so I'll talk about the vaccines. What are the benefits and risks? Well, first benefit is the vaccines prevent death. All three of the vaccines, now two, that have been approved for use in this country have been proven to prevent death. What are the risks? The risks are that there may be side effects from the vaccine, and I certainly will talk about those potential side effects. But the risk really, yes, that slide is fine. The risk, you know, in healthcare, we always talk about risk and benefit, and you just kind of have to weigh what's good for you in your life. Do the benefits outweigh the risk? Early on, we saw the vaccine being given only to people who had risk categories for becoming severely ill and leading to death, hypertension, diabetes, obesity, asthma, those kinds of things. And now the vaccine is opened up to everyone over the age of 16. I can definitely say there are more benefits than risks to both of the vaccines that are on the market today. Next slide. So what happens when you get the vaccine? Your ability to get infected is minimized, right? If you get infected with the virus, your course is shorter. You will not get as sick as you would without the vaccine, and certainly death is prevented. But what about transmission of COVID after the vaccine? I'm sure some of you, or hopefully most of you, have been vaccinated. And if you have, what's important to know is even though you have been vaccinated, there is a possibility of transferring that disease to someone else. You can get infected, you won't feel the sickness, but someone else may get it from you. You can spread it. So therefore, we're continuing to wear the mask, social distance, and to hand sanitize frequently. So that's going to be important. And I think that's the world we are going to live in for at least another year until we can get a handle on what's going on. Next slide, please. So with the vaccinations, there are lots and lots of issues around vaccines. There's a lot of hesitancy to take vaccines. And mainly the hesitancy at first was, oh, it came out too quickly. I don't know what it's going to do to my body. And then there were lots of conspiracy theories on the internet, and that would prevent people from being vaccinated. So what happens? There are potential side effects. The side effects we'll talk about later, but the side effects are really short-lived. They last 2 to 3 days, at the most maybe a week, but after vaccination, you know what the side effect is. You rest, you take your, Tylenol afterwards if you want, and you can function. Once you know that they're short-lived, it's pretty easy. So now we're in a second phase of what I call vaccine hesitation. And that is where people are saying, look, I don't want to get the vaccine because I don't want the side effects that I'm seeing happening. Again, for you, for each person's life, it's about weighing the risk and the benefit. And some of the risks include, if you get sick, include making others sick. So if you live in a home with elderly people, if you have children, if you travel a lot, if you have underlying illnesses, all of those are risks for either transferring to someone who could be severely infected by it or getting sick yourself and getting very sick. And right now we have no way to know why some people get really sick and get better, and then other people get really sick and they die. That is under discussion right now. If we had that figured out, we would do probably something differently around who gets vaccines, but we don't know. We don't have the answer to that question yet. Side effects. So the side effects really are short-lived, as I said, and they can range from from a little arm pain, redness and swelling at the arm. Sometimes people get, some illness, some nausea, chills, fever, diarrhea. Short-lived, 2 to 3 days, at most a week, people are back on their feet. The feared complication side effect that most people hear about is something called anaphylactic shock. And that is an immediate reaction, immediate meaning anywhere from minutes up to about 15 or 20 minutes, where the patient or the individual will have difficulty breathing, swelling of the face, a rapid heartbeat, rash, dizziness, and they can pass out. That requires immediate medical attention. So wherever you see vaccines being given, they have emergency equipment. Those instances have been very rare. Out of the, I forget, over 35,000 in both studies with Pfizer, it was very rare. It's happened, I believe, once with Pfizer vaccine since it's been out. Right now in New York State, we have 20 million people who live in New York State, and we've given fully vaccinated about just above 2 million people, and we're doing fine. So the Johnson & Johnson side effects, that's the other thing you heard on the news recently. Johnson & Johnson has provided vaccines for many people, and out of it, there were 6 individuals in this country between the ages of 8 to 48 women who've had side effects that is a rare type of blood clot. So Johnson & Johnson vaccines, which the vaccine is the one dose, which people were waiting for, the one shot, The other vaccines require 2 shots. So Johnson is 1 shot, but that has been halted until further investigation can be done. And so some people may say 6 out of 15 million vaccines, what's the big deal? Well, it's a big deal because we want to know exactly what is going on with the vaccine. Is it having an effect on just certain types of people with certain types of underlying conditions? And we're waiting for that information to come out as soon as possible. Next slide. So, okay, that was an overview because I only had a few minutes, but I do have a lot of questions here that were sent to me, and perhaps we can talk about them later because I know Dr. Moore needs an opportunity to present. But what I would like to say is, please, if you're considering the vaccine, just considering your individual risk and benefits and the benefits or risk it may bring to your family to be vaccinated or not to be vaccinated, and speak with your doctor. All right, so I'm going to end my portion and turn it back over to the moderator. Thank you.
Thank you, Dr. Bookhardt-Murray. I will now turn the floor over to Dr. Donald Moore. Dr. Moore is a private, independent primary care physician in Brooklyn, New York. He is an attending physician at the New York Presbyterian Brooklyn Methodist Hospital, where he chairs the ethics committee. He is a clinical assistant professor to medical students from Weill Medical College of Cornell University and SUNY Downstate Medical School. Dr. Moore serves as the president of the Providence Clinical Society, the Brooklyn affiliate of the NMA, National Medical Association. He is also the president of the Association of Yale Alumni in Medicine, president of the Medical Society of the County of Kings, and chair and member of many committees in both the state and county medical society. His scholarly activities include lectures on health reform and health disparities. He is the recipient of the Distinguished Alumni Service Award from the Association of Yale Alumni Medicine. And he is teaching excellent, and he had been awarded teaching excellence from Weill Cornell Medical School. Dr. Moore is the chair of the Health Information Technology Committee of the Medical Society of the State of New York. And I could go on, but I don't think we have the time for all of his compliments. So I'll end by saying that Dr. Moore, the floor is yours.
Thank you very much, Professor Weston. Well, you know, I think whenever I would go up to Yale, my alma mater, medical school, they would say, oh, the general practitioner from Brooklyn. So I think that sums it all up. So, you know, all my life, I've been in practice for quite some time. And all my life, I've been waiting for, you know, something to happen. First, I said, well, gee, I've had a nice, easy life. And then a lot of catastrophe came. So I said, well, maybe, you know, I'll accomplish something while I'm practicing medicine. And just as I'm ready to pack my bags and get out and retire, here comes this pandemic. They say it's a 1 in 100 year pandemic. And, you know, when this all started, I didn't think that this would go anywhere close to the influenza pandemic of 1918. But this morning I looked at the amount of people that have died in the United States of COVID-19, and it's well over 500,000, approaching 600,000. And as you know, back in 1918, certainly 675,000 people died in the United States. So this may be the pandemic for quite a few centuries. So what's the role of vaccines in this pandemic? In my opinion, the vaccines are great, but they are a little late because I've already told you that we're well well over 500,000 people, certainly in the United States, that have died, and over 3 million people worldwide. So clearly, well, I think the problem is we don't know when it's going to end. That's the problem. So we could just keep going on and on. As a matter of fact, back in January, it looked like we were peaking. And by February, I was saying, oh, if you look at the pandemic curve, and I'll talk about that in a minute, it looked like we were on the way down. But here we are in April, and guess what? Looks like there is another peak where, you know, not just in the United States, but worldwide. As a matter of fact, it looks like we haven't even peaked worldwide. So, you know, the pandemic curve, or the epidemic curve, of these waves that go up and down. Typically, in 1918, we had 3 of them. You know, the biggest one was the second one. The first one was, you know, pretty devastating and killed a lot of people. But the second one was the one that did most of the damage. As a matter of fact, the number is 50 million people plus that died in that pandemic. We're up to 3 million worldwide at this time. You know, you would think in a country like America, we would pretty much be doing well. You would think that we would do fine in a pandemic, given the amount of money we spend on healthcare, given the infrastructure that we have, given the fact that you can get the best healthcare in the world in America. But we have the distinction of not just having so many deaths, but having the most amount of deaths worldwide and the most amount of cases worldwide. So I'm gonna show you what I mean about these pandemic curves. So you should be seeing my screen, and if you're not seeing my screen, somebody should tell me, but I think I'm sharing it. Am I sharing my screen? Did I get a yes?
We are not seeing your screen, Dr. Moore.
Thanks for letting me know that. So I'm gonna just do that, and I'll try again, share screen. And okay, now I know you're gonna see my screen because I didn't do it right first time. Okay, you see it now. So those are the 3 million people we're talking about. So these are the pandemic, this is the current pandemic curve for the entire world. As you can see, there was a wave back in March. Right here, that's when I got excited, because that's when we all got excited. And I remember back in March of 2020, the way I used to diagnose COVID-19 was I would listen to the symptoms, I would read the CDC guidelines on what the symptoms are, and I would say to the patients that I had, you have COVID or you don't have COVID, I don't think you have COVID. And half the time I really didn't know, but when they died, I really did know. We didn't do very well at the beginning, because in the beginning, we didn't use the tests that were available worldwide. We wanted to develop our own tests, and it took us a while to get there. But when we did get the tests, it looked like we had a whole lot of people that had it. But I want to show you these ways. I want to show you here that the world, I thought we peaked back in, see if I can make this a little larger so that we all can see this. All right, I'll move it out here. Okay, so it looked like back here, this would have been in the summer. Looked like we had peaked somewhere. This would have, maybe in the fall, but then, and it was coming down. So it looked like COVID was ending, but then boom, we started going up here again. And as you know, the deaths from COVID track behind. So this, on this side, is the death rates. And as you can see, worldwide, we're looking at almost 1 million cases a day that we're seeing at this time. This is April 16 that I'm highlighting. Anyway, moving here to the United States. So on this column here, this is the amount of people who have had COVID worldwide. And this is the amount of people who have had COVID in the United States. 32 million so far. India is not far behind Brazil. So you've heard of all of that. What makes it so bad for us in America is that we don't have the population of India. You know, we are 332 million people. India is 1.3 million people. So even though you look at what's going on a daily basis, there are more cases that are occurring in India. We top these numbers when we were peaking, and not everywhere in the world peaks at the same time. If you recall back in March and April of last year, 2020, you know, the amount of cases in the United States was relatively low, but it was really bad in New York. It started in New York. We were the ones who were hit first. And guess what? Brooklyn was the epicenter. There was no place in the world that had more cases and more deaths than Brooklyn. Brooklyn had the most cases in the world and the most deaths in the world. Well, Queens maybe a little bit more cases, but we had the most deaths. And for those who could remember, and I remember clearly, it was eerie. You know, people were, I mean, you heard the stories about the refrigerated trucks, you know, people passing by and smelling. So I don't want to be too graphic about that, but I want to point out that it was really, really bad. And it's still really, really bad. It's still really, really bad. So anyway, the numbers you're seeing in India and Brazil don't touch what we had in New York and in the United States. I just want to draw some kind of a contrast here. You know, I would have to go way down to the bottom of the countries. These are all the countries. There are over 200 countries on this. And if you look for China, which has, you know, 5 times our population, they're somewhere way down here. You know, they get lost. So I'm saying it's not because we have a lot of people. It's because we didn't do well in this particular pandemic. And it may be a reflection of a lot of things. It is a reflection of a lot of things. So what I want to do is to focus now on New York. So if we hit the United States, we saw the numbers I talked about, and we're gonna get to New York over here. So of course, California has more cases because they're much larger. They're twice as large as us in New York by population. California has, you know, population of almost 40 million people, and you heard in New York we have 20 million people. So it's understandable that they have more cases. Texas, they're 50% larger than New York. They have about 30 million people. Florida has just about the same amount of people as in New York. So even so, you look and you say New York doesn't have that. You know, we're 4th in terms of the amount of people that got COVID, but we're relatively small compared to the other states that are ahead of us. As a matter of fact, it shows that the whole country is pretty much doing about the same as far as the amount of COVID that we're all getting. So, you know, how do you then compare? Well, you compare by looking at the people that died. That's the important thing. I told you 50 million people died worldwide on that last pandemic in 1918. And I mentioned to you that 675,000 people died in America. But how do you compare different populations? You look at the death rate per population. You could either say the death rate per 100,000, or you could say the death rate per million. In this case, they're looking at the death rate per million. So I'm going to hit that bar, and it shows you the death rate in this column per million people. You see, number 1 is New Jersey, you know, attached to New York. Number 2 is New York, really high. Number 3 is Massachusetts, Rhode Island. So if you look at the death per population, it tells you that no matter what you hear about the South, no matter what you hear about Michigan, no matter what you hear about California, this disease was concentrated in the Northeast, just that it was concentrated in certain parts of Europe. So we really needed some type of rescue. So my point is, when the vaccine came, and I'm going to go back to the graph here to show you, to explain to you what has happened. So this is the cases in New York. And this is all the way over here was March when I told you about that horrid scene. This is in the summer. This is what happened around Christmas time and this is what happened. Actually, this is the United States, and this is what's going on now. But if I bring up, I'm just gonna go to New York because that's where we are, and I wanna sort of focus on that one last time. So you could see in New York that first pandemic wave was, we peaked out at about 11,000 cases a day. And that now in this past January, February, we went all the way up to 20,000 cases per day. Fortunately for us, our death rate the second time didn't go as high. And the reason why it didn't go as high is because we kind of got better. Maybe all the people who were more vulnerable died. And so even though the amount of cases went up, the death rate didn't go as high. And that sort of left us in a better position. But we still have the highest death rates, certainly in the region and worldwide. So the vaccines came at a time when we were already on the way down, both nationally and locally. But the vaccines are very important because, as I mentioned at the beginning, it doesn't look like we know when this pandemic is going to end. And if the disease still exists in the rest of the world, which most places don't have vaccines, it is very likely that it's going to last a while, even after we reach a point where we say we will have a certain amount of herd immunity, which basically is enough people have already been infected, plus enough people would have already had the disease, so that when somebody gets the disease, it's not going to spread too far. So from the point of view of herd immunity, even if we get that and the disease is percolating everywhere else, then we may become susceptible, because we have also seen that people who have been infected can get infected a second time, and there's a tracker that tracks that, where we know at least 71 people worldwide have got a second infection, but many people who have also been vaccinated have had a second infection. But here's the key: if you get vaccinated, your chance of getting really sick the first time is really low compared to if you're not vaccinated. And if you are vaccinated and you get the disease a second time, the likelihood that it's going to be a bad disease is much lower than if you did not get the vaccine. So I'm going to talk now a little bit about the vaccines themselves with a little bit of granularity. I'm going to dig a little bit deeper here. So, vaccines, they've been around for thousands of years. Really? Yes, vaccines have been around for thousands of years. So when did this whole thing vaccine start? Well, in the United States, if we go back to the 17th century, so that would have been 16 something, when certainly science didn't exist to the way we know it today, with respect to, we didn't even know about viruses back in the 17th century, but they had pandemics. So around 1721, back in Boston, there was a smallpox epidemic, and Cotton Mather, who was a Puritan minister, he had this slave that he was gifted by his congregation. They gave him a slave. So of course, back in those days, people were very concerned. You know, slaves are human beings. They can spread disease to their masters. So there was a lot of concern. You know, if I get a slave, is that slave going to give me smallpox and spots? And am I going to die? So they would want to know, have you had this disease before? Because they knew if you had smallpox before, you weren't going to get it again because you had natural immunity. So when Cotton Mather asked his slave, he named him Onesimus, if he had had smallpox, he said, well, kind of. He said, well, you know, Cotton Mather was a very intelligent man. He said, well, what do you mean kind of? You either had it or you didn't. He said, well, I kind of had it. And he explained to his master that in his practice in Africa, in the practice where he came from in Africa, they would inoculate the people with the extract from a pox, and they would scratch it in the skin, and the individuals would then get a milder form of the smallpox, and that was called variolation. It took another 300 years before we got to vaccination. But the point is, even back then, Cotton Mather was very smart when during that pandemic, he was able to convince a physician. And of course, at that time, the knowledge people were the ministers. The physicians were not as knowledgeable at that time. And he was able to work with Boylston, a physician, to inoculate a group of people. And that was really, from my understanding, the first real good clinical trial on vaccines. The people who they were able to inoculate, to variolate at that time, had a much lower rate of disease. So the concept has been there for thousands of years. So move forward this 400 years to where we are now, and you heard about the vaccines being developed rapidly. And I want to address that. The vaccines were developed rapidly, period. So anyone who says, yeah, that came pretty fast, it has merit to say that. The reason why it came so fast is because we used to do phase 1, phase 2, and phase 3. We used to do the animal studies before we started. They started everything at one time. We didn't do phase 1 and then phase 2. We did phase 1, phase 2, and animal studies simultaneously. So we took a chance. Usually they wait till they prove that you're successful in 1 and 2, and then you go to 3. We started phase 3 before phase 2 was finished. And we got to the point of inoculating people, vaccinating people, not after we approved the vaccines, because none of the vaccines have been approved. We started inoculating people before we finished the studies. So if one says these vaccines are experimental, they're absolutely correct. The good news is that eventually these vaccines are going to be licensed. And when they are licensed, in my opinion, we'll probably have the same results that we have seen now. As a matter of fact, what we're seeing as we have moved the vaccines out worldwide and nationally is that the vaccines are performing as good as they did in the clinical trials. So, so far, everything is going pretty good. So, what about the side effects? The long-term side effects? You won't know the long-term side effects because you haven't gotten to the long-term. You know the short-term side effects. The short-term side effects are the same as the short-term side effects of all the other vaccines. When I took my shot back in Jamaica, and I forgot what that one was, but I got this big mark on my arm. You know, fortunately, when I took my flu shots, I didn't get this big mark on my arm. I got a little pain in my arm. So those are common side effects. But there are going to be some rare side effects. We've had influenza vaccinations that cause neurological complications. Yes, the Guillain-Barré syndrome, which was caused by the swine flu. So we've gone through all of that year after year, and we get better with it. But it is better, you know, if we had a vaccine back in 1918, and we thought we did, they were giving serum back then and thought they were doing the right thing, we wouldn't have had 670,000 people, 670,000 people died. If we had a vaccine then, we would have really, you know, if we had it at the beginning, we would not have had that many people. As a matter of fact, we haven't seen that many people die with any influenza pandemic since that time. So vaccinations really have changed, but for this particular one, the vaccines are a little late and they may help to end this at the end. What has really helped us is common sense. If you recall, when we all started this, you know, we were walking around, breathing on each other. We were still going to the restaurants. We were doing all of these things. And then we realized, wait a minute, this thing is in the air. Let's cover our faces. Makes a lot of sense. Cover your face. You know, you will reduce the transmission. I took a plane this weekend, and guess what? You know, they didn't have anybody sitting next to me. I was very happy. I was double masked with my N95 and my other mask. If you're in a plane, and somebody's in that plane that's sick, it's going to circulate. So what we're doing makes a lot of sense. We're screening people. We're trying to make sure somebody that's sick don't come into our presence. We keep them isolated. We keep them quarantined if we're not sure. So all those things make sense. But the vaccines is an important part at the end of all of that to stop any further progression, because we don't know when this thing is going to end. So there are a couple things, though. There are issues that are brought up with these vaccines that I think we have to address. First of all, there is hesitancy. Of course, I'd be hesitant. I'm hesitant when I walk into a hospital and I'm a doctor, because it's not always a good place. It's not always a friendly place. It's not always a place where the people have my best interest at heart. So I know that, and so I will take my own precautions, but at some point, if I know that 911 came and collected me and took me to a hospital because I can't help myself, most of the time I'm going to do okay. And so I think, again, it makes a lot of sense that, take your chances with vaccinations, because it's the best we have. We don't have any really good treatment for this disease. If you get really sick, we're going to put you on steroids and you might make it through. The best way, as we all know, of not dying of a serious disease is to not get it in the first place. And if you can prepare yourself so that if you get it, you're likely to do better, then it makes a lot of sense. And this is what this particular series of vaccines do. So let me close this off by saying, so you've heard in the last few weeks, last few days, that one of the vaccines caused a serious complication. Yes, the cerebral sinus thrombosis, which is a blood clot somewhere in the brain. Well, you know what? The disease caused a lot of blood clots. What I saw, the reason why a lot of people died back in March in New York and April in New York is because they were getting blood clots. They were getting blood clots in the brain. They were getting blood clots in their legs. I saw those cases, so I can understand why the vaccine might do the same. Well, the good news is that we don't see it very often. It's extremely rare, and we're just gonna have to accept side effects. Every medicine has side effects. Every vaccine has side effects. But you also have a brain, and you don't want blood clots in that brain from COVID. The blood clots you get from the vaccines are gonna be a lot less. So when they finish that pause, and they're gonna bring the vaccine back, because it makes a lot of sense to bring that vaccine back. When they bring that vaccine back, and that's the vaccine you can get, I would suggest you take it. I was hesitant. I am hesitant for vaccines. But when February came and I saw that, by February, I think in America, we had given the vaccine to at least a couple million people. I saw that the vaccines were working as well as they said in the clinical trial. I took my vaccine and I did pretty fine. With respect to the long term, I will see what happens in the long term. But if you die from COVID, you won't have any long-term COVID effects. So that's the story there. People die after they take the vaccine, as they die after they take any medicine, or they die whether they take a medicine or not. The chance of dying after you take the vaccine, any vaccine of the 3 vaccines that are used under emergency use authorization, is actually much lower than COVID and not much higher than what occurs under normal circumstances. So I'm going to end it there, because there are a lot of questions that need to be asked, and I'm right here. Thank you.
Thank you very much, to both of you. We appreciate your insights into this issue. We do have a fair number of questions, and I will try to summarize those that seem to group together. We have a question about the 3 different vaccines, and this can be addressed to either of our presenters. Which of the 3 vaccines that are available have the fewest number of problems, side effects, and deaths?
Well, let's see. They're pretty comparable. I am going to not bring Johnson & Johnson into it at this point because that is on pause and there is still a lot of evaluation going on around the Johnson vaccine. But when we come to Pfizer and Moderna, there has been data that shows that Moderna probably has the least number of side effects, although it's really negligible in my book. And the side effects are the same. The potential side effects that people experience are the same for both vaccines. Dr. Moore, you may have more insight on that.
Yeah, so the side effects, again, are pretty much the same. The serious side effects are minimal. So I agree 100%. Moderna and Pfizer, they're absolutely the same platform. They're made almost exactly the same. They are pretty much pure substances. There's not much preservative or anything in them. They're just really, you know, the messenger RNA vaccine is a nucleic acid, just a clean piece of nucleic acid covered up with a nanoparticle, which is just a piece of fat. And then they put it in regular saline, salt water, and that's what you get. You get a pretty clear, clean injection. So there isn't much of that. The reason why you feel it there is that's what we call reactogenicity. When the vaccine is injected to you, it starts working in the muscle and then it gets to the cells and your arm becomes a manufacturing plant. Your whole body becomes a manufacturing plant for antibodies to deal with any virus, any coronavirus that will attack you after you're fully vaccinated.
Okay. Thank you. How do people know which vaccine is best for them?
Well, I think that's been answered. The side effects are pretty much the same. The mRNA vaccines are made on the same platform. And really, I tell people to go where they can get the vaccine most easily and most readily. Where you can get it the quickest, that's where you should get it.
If I may just add to that answer, one little point. I think, and I don't want to be ahead of our experts, but I think what we're likely to see when the J&J comes back, we will have some caveats on who should take that vaccine. Because of the thromboembolic, the blood clot phenomenon that we have seen, it tends to occur in younger people. So it is likely that they may recommend that you limit the use of the Janssen or J&J vaccine in younger people. Limit the use. Younger people don't take it as much, or young women who seem to have a greater likelihood of getting the blood clot. So that may be a slight variation.
Thank you. Are there medical restrictions about who should get vaccinated?
Well, there are some precautions that we take. So there, the vaccination really needs to be discussed with the doctor, but certainly anybody who's received who's been infected and received the plasma, the antibody plasma, they should wait for about 90 days before they get the vaccine. There may be some side effects, increased side effects if they do get the vaccine. And there are other people we ask to wait. For instance, if they've had COVID-19 infection, we ask them to wait, but that's really because they have some protective antibodies there that should last for about 3 months. And when the vaccines were first rolled out, there was a shortage of vaccines. And so we were trying to conserve and make sure it got to the people who needed it most. The other would be, people on chronic treatments, chemotherapy, chronic steroid therapy. They should really speak to their doctors about which vaccine and when they should take it. It's really timing of the vaccine in that case. But there are no real contraindications as far as those precautions. And also for people who have allergies to any of the ingredients in the vaccine, they should not take the vaccine. So if you have a lot of allergies, the ingredients are easily looked up on Google. There's a list of them. And if you have any allergies to those ingredients, you shouldn't take the vaccine.
Yes, I agree.
Thank you. There have been a lot of questions regarding pregnant women, the effect on fertility, the effect in the future if people are pregnant or plan to get pregnant, and the vaccine. Could you address those, please?
So in the immediate future, there is no real contraindication for pregnant women to get the vaccines, but that is based on animal studies. There have been no problems with fertility or problems with the offspring in animals, mainly lab rats who've gotten the vaccine. Of course, we get back to the question of long-term vaccination side effects. And like Dr. Moore said earlier, we haven't been at this long enough to know what the long term is. So we're really dealing with the most immediate situation right now. But it is a discussion for pregnant women to have with their doctors.
And if I may add, in general, we've given most vaccines, unless they're live vaccines, most vaccines so far have seemed to be okay with pregnant and breastfeeding women. However, I have a story. I have a close relative who asked that question because she had just delivered a baby. The baby was when the vaccines became available, she was in late pregnancy, and then the delivery occurred and she was breastfeeding. So the question is, and it was apparent that the vaccine would become available to her. So the question was, should I take the vaccine? And this was asked not just as a doctor, but as a close relative informing. And I said, I don't recommend you take the vaccine because you're isolated for the moment, and you can wait and see. Of course, remember, we don't have much data, and these are still experimental products. Well, lo and behold, this person, this close relative, the husband got COVID, she then got COVID, and the two babies, the 2-year-old and the weeks old baby got COVID. So then, of course, I asked the same question to her. I said, okay, you got the advice and you acted on the advice of not taking the vaccine. Now, having had COVID and seeing the situation here, what would you do if you had to do it again? And she said to me, I probably would take the vaccine because COVID is not easy. Because they're young and they're all healthy, they appear to be doing fine and will do fine. We don't know what the long-term effects of the COVID would be, and we wouldn't know what the long-term effect of the vaccine would be. So I bring the story to show you that there are no clear-cut answers. And even when you give an answer, you still go back and you said, I wish I would have done it that way. But this is the situation of this particular person who I know who said, I would have done it differently. I would have taken the vaccine.
Thank you. I have a question here from Jonas, who asks, what is the COVID-19 vaccine made out of? And how have the components been proven to be safe?
Dr. Moore?
Yeah, all right, I'll start with this one. Okay, so okay, so there are 3 of them. So let's just limit it to 3. There are about 6 platforms that we have, so you could make it in 6 different ways. So the first 2 was made of a nucleic acid product. So in a lab, the scientists made a nucleic acid. It's Moderna. Moderna was a company, modified RNA, Moderna. That's how that came about. So they took they actually created something that looked like an RNA. So it's made of a chemical product, a molecule. And this is just one, and this molecule was made to look like a part of the spike protein that sits on the surface of the virus. So what they did was they actually took a virus, sequenced the virus and said, okay, this is what the spike protein looks like. This is the sequence of that virus, of that portion of the virus. Then they copied it and then made a nucleic acid. Messenger RNA is actually sort of a copier, a copy machine. And they made that and then wrapped it up in a piece of fat, injected it in the person so that then that same product could be made inside the body. Once that facsimile of the spike protein is made in the body says, wait a minute, this thing wasn't here before, it must be foreign. It's an antigen. So the body then creates antibodies to attack it. When the natural virus comes, the body now is prepared. You have a group of soldiers who are ready to attack it. So it's made of just a clean piece of messenger RNA covered with a clean piece of fat and a little bit of fluid. And that's the Pfizer, the Moderna. I think they put a couple of salts in it just to stabilize it. So that's that one. When you're dealing though with J&J, you're dealing with a different platform. That one, they actually took a virus, adenovirus, which is a common virus. Then they took that virus, they took a they took a portion of it out, inserted DNA material into that virus, made the virus inactive, so it couldn't replicate or do anything, and then injected in you so that when that inactivated virus material, we'll call it virus material because it's no longer alive, it can't reproduce. When that goes into your body, it then travels to the appropriate part of the body, and I'm going to tell you what it is, the nucleus. It goes into the nucleus, and then the nucleus makes the messenger RNA there. And the messenger RNA comes out and does the same thing as the other one does. So again, we're dealing with this is science fiction stuff. This is where we're gone with science. So it is not absolutely not computer material. It's not a thing that's going to direct you to become a zombie or anything like that. No, it's real science that has developed to this level. And we've been using this stuff for a while. We use this stuff to treat cancer, which is, it's the same technology we're using to treat cancer and we're using to treat autoimmune diseases and so on. So unfortunately, let me just say one thing about these vaccines that exist today. Unlike previous vaccines where we would actually take the germ, whether the germ was a bacterium or the germ was a virus, and then we would kill that virus or inactivate it. make it so it doesn't work, and then inject that in. Now we're using more pure substances. We're using portions, or we're making it in the lab. I always tell people, if you can make a pure substance, it is much better than trying to extract what you want from a natural product, because then you get a lot of junk with it. So here you're getting a pure substance, and you can then dictate how that substance is going to work. So again, you're dealing with materials, pure materials, water, saline, which is salt and water, with the specific thing that you're looking for.
I just want to add to that, it is not possible for the inactivated product or for the messenger RNA with the Pfizer and Moderna to become a whole virus once it's in your body. So I know there are some thoughts out there that the virus is being injected into the body, but it's not possible for it to become a whole virus to make you sick once the vaccine's injected.
Yes, and the messenger RNA, they're not viruses. They're not viruses. They're adenovirus, which is the J&J, that is a virus. But the messenger RNA are not viruses. We're not injecting viruses there.
Thank you to both of you. I have a question here from Evan, who asks, and you've addressed these certainly, but I want to repeat this. What evidence can you cite that these products prevent death? Can you prove that the chance of dying after you take the vaccine is less than the known infection rate of COVID-19?
Both of the studies had over 35,000 people enrolled. And so we have evidence there. When we talk about the vaccine being rolled out quickly, I think the other part of the science that was rolled out very quickly was the study, the research that went on with, each vaccine. I think Pfizer even maybe had 45,000 people enrolled in their study, and Moderna wasn't far behind. So that's the evidence we use.
Yeah. It does prevent death. And how do we know? Because let's look at the Pfizer study. 43,000 people, 20,000 people got placebo, which is just plain old saline, salt and water. 20,000 plus people got the actual vaccine. They waited till people got sick. Nobody died at that point. They just waited till people got sick. Nobody died in the study. Of the people that got sick, the first 170 people that got sick, 168 came from the placebo group, which means they didn't get any protection. And only 8 came from the vaccine group. Hence, we did the calculation to say that Pfizer was 95% protected. And it was the same with the Moderna. The two different vaccines come up with the same number, 95% protective of severe disease. Now, I showed you, the reason why I showed you those graphs before is because if you get a lot of COVID cases, you're gonna get a lot of death. They won't occur at the same time. The case is gonna occur because for you to die, you've got to start off with the disease, then you've got to get sick. If you make it to the hospital, we're gonna try and save you. If we don't save you, you go on a ventilator or whatever, and then you die. If you don't get the disease at all, you're gonna die of something else. You're not gonna die of COVID. So that's the evidence. The evidence is that all the vaccines, including the J&J, prevent serious illness, which means you don't get to the hospital and you don't get to die.
Dr. Bookhardt?
Yes, so I don't have anything to add about that. You really need to delve into the studies. I was looking, there are other questions coming up about the same issue.
Okay, let me change tracks a little bit here. We have a question from Julie. How would you go about encouraging skeptical family members to strongly consider getting the vaccine, assuming their doctors also recommend that they get it?
Look, there are a number of people, no matter what you say, they are not going to get the vaccine. We know that. And I think for New York State, we're anticipating probably about anywhere between 5 to 10% of our population are just going to say no, just because they don't feel comfortable. I never push anyone to do something they don't want to do. I talk to them about the risk and the benefits. I talk to them about how it will personally risk or benefit that individual, and then encourage them to make a decision based on the information, credible information that they have. And with some of my patients, I'll actually sit there and go through, pull it up on Google, go to the CDC, I'll go through the evidence with them and allow them to really think about it. There's no way to push somebody to do a vaccine. They have to make their own decision.
For those of you who have heard my comments on this, I don't think anyone should be mandated to take an experimental product. I think it's the responsibility of our government and the responsibility of the companies to go and get a biologic license. The reason why the medicines are under emergency use authorization is because we wanted them sooner than later. To get an emergency use authorization, you only need 2 months of data. To get a biologic license, you need 6 months of data. At least that's been our practice. That's been sort of our habit. So it's now 6 months. So we don't want the pharmaceutical companies to get away with, oh, we can keep giving these vaccines out without providing any additional information. We got information back in December, November, December, based on data that we collected from September and October, and those were the numbers we gave you. Now we know they have more information because they have been monitoring. The people have been in trials. People are still in these trials. So, the social responsibility of you and me is to go to our elected officials and say, okay, it's time to bring out more information, make it plain. I think more people will be convinced to take a vaccine that has a license. And if I may take this one step further, if you took one of the vaccines that are currently under emergency use authorization and you get a major side effect, you're hurt, you're injured, you may not be covered by vaccine injury protection, which is what your government allows you if, especially when the government owns the vaccines and is behind the administration of the vaccine. If I give you a flu shot and you get hurt from that flu shot, you're covered. So we want the coronavirus vaccines to be under the same protection. So I think from not just a public health point of view, but from a medical legal point of view, we want that protection for these vaccines. And I don't think you should wait until the vaccines are licensed to take it, but you should make sure that your government officials push the pharmaceutical companies to apply for their biologic license.
Okay, thank you. Can a question from Suying, can the Pfizer and I'll add Moderna vaccines protect recipients after a single dose?
So the Moderna and Pfizer, as you know, requires 2 doses, each one. And the first dose is what we call the priming dose, right? You get a first dose. It allows your immune system to recognize this foreign material that is there, allows, Dr. Moore did an eloquent job of explaining how it gets into the nucleus makes proteins, it goes to the cytoplasm, releases these beautiful things called antibodies that protect us against infection and other diseases. And so once you get the first vaccine, takes about 2 to 3 weeks. The immune system is primed so that when it sees that same antigen again, it will have a more robust response. That's the second shot. That's the job of the second shot, that it will have this robust response and that the memory of that response is embedded in your DNA so that when it sees it again, it will have that same response to fight off the infectious agent.
So, you know, medicine in general is never a, you know, yes, no, on, off situation. It's usually a continuum, just like we talked about before immunity, when the population becomes immune. There is not one day where we'll say, okay, we have herd immunity in America, or one day we have herd immunity worldwide. It's a process. Well, it's the same thing. If I give you a vaccine today, you know, it's not just day 3, boom, you have some protection, or day 7, you have some protection. That protection starts and it gets to a level. It gets to a threshold where we say, yeah, that's where it's optimal. And that first dose does not take you to the optimal place. It takes you to a better place than you were without a vaccine. And again, I'll use a clinical example. There is a woman who basically did not get her vaccine yet. She lives with her husband who got coronavirus. So he got sick. He ended up in the hospital. He's got blood clots, right? He never had his vaccine, so it wasn't due to the vaccine. He had blood clots in his leg and he's in the hospital and he's very sick. She tested negative. However, she had had 2 vaccines. And I know beforehand, before she got her vaccine, that she had never had coronavirus because I had checked her antibodies periodically. So the question was, if she had to, and of course, she's not very ill, but she's not herself. So when the daughter spoke to me about her, she said, well, you know, she's sick, but she doesn't have coronavirus. And I said, well, maybe she does, because she has some symptoms that suggest to me she has coronavirus. But how could she get it having had 2 vaccines? Well, she could, because again, this occurred within a relatively short time after having had the vaccines. And we know the vaccines protect you, but we know they don't protect you 100%. So it's that continuum. So it is good. You get some protection after the first, and it's good. So get it as soon as possible. But get the second one, because you need to get to that maximal possible level that you can get to. And that's the real answer to the question, because there is a lot of disease states in between.
Thank you. We're not going to get to all the questions clearly, but I have a few more. Here's one about how soon do you think we'll have a vaccine for children under 16, and are there things to consider when vaccinating younger children?
Well, I don't know when we'll have that vaccine. Pfizer is actually studying that right now. And the preliminary data shows that it is safe. But, you know, as you know, they need to have a large number of people enrolled in the study. Initially, they had some difficulty getting children enrolled in the study, but so far it looks pretty promising. And I don't know how quickly that will come out. Dr. Moore, you have any updates on Pfizer?
I think they're the closest, as you said, and if I'm not 100% sure, but I think they have already made their intention to apply for emergency use authorization. So that process is 1 to 3 months generally.
Oh, okay, thank you very much. I'm just trying to watch our time here. Will people with pre-existing health conditions be affected more by one vaccine than the other? What might be a problem there?
Let me talk about one pre-existing condition that I've seen in my practice. If you're immune suppressed, let's say you have cancer and you're getting immune suppressive drugs that damp down your immune system, and I vaccinate you, you may not get the same protection as the people in the studies. So that's one pre-existing condition that we need to monitor carefully. Again, the recommendation is even if you are immune suppressed and you have pre-existing conditions, still take the vaccine, but you may not be protected to the same extent. All of the pre-existing conditions, unless it's hypersensitivity to a vaccine component, everybody should get it.
And speaking of pre-existing conditions, HIV is being studied by the Pfizer company as well to see what happens. We know that is an immune deficient disorder, so they are looking at that. And we see that with other vaccines as well. In people with immunodeficiency, we just don't get the desired response to the vaccines that we would like.
Okay, we have basically 1 more minute before we launch our closing poll. I'm very grateful to both of you for this, but can you, in 1 minute, do you have in 1 minute any kind of closing statement?
Well, my closing statement would be that I would like each person to seriously consider the risk and the benefit of vaccine. Don't just wipe it off and say, I'm not going to do it, but really delve in, look at what it means for you and your family to be vaccinated.
Yeah. And, think of vaccines as just part of managing your health. If you're in a pandemic. So one, you need to maintain your health nutritionally, meaning you need to eat well, you need to exercise, and take drugs that are appropriate for you to take. Don't go off course. The reason you have an FDA, the reason why you have a CDC, the reason why you have doctors is because you contribute your resources to develop this infrastructure. So use it. Listen to the CDC, listen to the FDA. They do bad things sometimes, but you should be able to figure out when they're on your side and when they're not.
Thank you very much. Professor Horlyck-Romanovsky, you want to?
Yes, thank you so much. Thank you so much. I'm going to launch the post survey, our exit poll. So please, there's only one question on this. So I'm going to launch that. And then I want to say that unfortunately we are out of time. And but I want to let you all know that we welcome you to submit any questions on social media. I'm going to post our social media handle and our hashtag in the chat, and that should go out to everyone. And we really are grateful to our panelists and our planning committee for spending this time with us, and for all our participants for joining us. We will try to follow up on all the questions that were submitted in the Q&A on our social media profile. I also want to let you know that the recording will be posted on our YouTube channel. It has been live broadcast through our student government, but we will also post the recording afterwards so that you can rewatch and re-listen. And again, we encourage you to submit questions through social media, Twitter, Instagram, and then follow us on TikTok and participate in our COVID vaccine dance contest. So once again, thank you so much for everyone who came, and for especially to Drs. Bookhardt and Moore for indulging our many questions. Professor Weston, I will leave it up to you to close us out for today.
Thank you, Professor Horlyck-Romanovsky. In closing, I must again express our thanks to our speakers, Dr. Bookhardt-Murray and Dr. Donald E. Moore, thank you. I'd like to thank also all those who have joined us to discuss this critical decision that you have to make. We ask you to care for yourselves and your families by grappling with the information that you have gained in the session and sharing it with those who you care about. The decision to take the vaccine or not to take the vaccine is a personal one. However, we ask that you make an informed decision and follow the decision with responsible action to protect yourself and those closest to you. Good afternoon, and may each of you stay safe.
Thank you.